Good morning. Today I'm presenting the management plan for Mr. L, a 56-year-old chronic smoker with newly identified type 2 diabetes, obesity, and clinical indicators of high cardiovascular risk. Mr. L presents with an HbA1c of 9.1% and a BMI of 30.9. Crucially, his admission for chest pain and T-wave depressions combined with smoking, hypertension, and high LDL places him in the high ASCVD, atherosclerotic cardiovascular disease risk category according to the 2025 ADA standards. My primary recommendation is to initiate combination therapy immediately because his HbA1c is more than 1.5% above target. A single agent is unlikely to be sufficient. First, I recommend a GLP-1 receptor agonist with proven cardiovascular benefit, such as semaglutide. The justification is twofold. One, it is specifically indicated for patients with high ASCVD risk to reduce the likelihood of major cardiac events, regardless of their baseline HbA1c. Now, I'll pass it to Ayn for further explanation.
Thank you, Chloe, for letting me continue. Second, an SGLT2 inhibitor like empagliflozin should be included. These agents offer complementary cardiovascular protection, particularly in preventing heart failure and maintaining a low risk of hypoglycemia. Third, we should maintain metformin as part of this regimen for its established safety and long-term mortality benefits. Finally, a critical safety note. Inhaled insulin is strictly contraindicated for Mr. L due to his status as a chronic smoker. In summary, by using a combination of metformin, a GLP-1RA, and an SGLT2 inhibitor, we're not just treating Mr. L's blood sugar, we are proactively addressing his obesity and high risk of cardiovascular death.
So Mr. L is a 56-year-old man with multiple cardiovascular risk factors, presenting with chest pain and also ECG changes. So you guys might wonder, what are the next steps? What are the most important issues that should be addressed in Mr. L? So first of all, for his acute presentation, his T-wave depression and also negative cardiac enzyme might suggest a non-ST elevation acute coronary syndrome, maybe unstable angina or maybe early enstoma. So I will confirm this diagnosis with serial troponins and also repeated ECGs. To manage his acute coronary syndrome, I would give antiplatelet therapy using aspirin or P2Y12 inhibitor, anticoagulant with heparin, nitrates for symptom relief, and also beta blocker if there are no contraindication. So beyond the acute issues, aggressive cardiovascular risk factor modification such as smoking cessation is also vital in this patient. So I would provide counseling alongside with pharmacological support such as nicotine replacement therapy such as bupropion to this patient. His LDL cholesterol level is also elevated at 3.5 millimole per liter. So I will start him with high intensity statin such as atorvastatin. His BP is also elevated at 140/75 mmHg. So I will give him ARB or ACE inhibitor. He is also obese. So lifestyle modification such as dietary changes and also regular exercising at 150 minutes per week is also required for Mr. L. So next, I will pass to Sophia.
In terms of his diabetes, his HbA1c of 9.1% indicates poor glycemic control, so treatment should be intensified with an individualized target HbA1c of around 7%. I will also screen for diabetic complications, including retinopathy with fundoscopy, nephropathy with urine albumin and renal function tests, and neuropathy with a foot examination. Given his current presentation, he likely already has underlying macrovascular disease, so assessment for peripheral vascular disease should also be performed. Foot care advice is also important to prevent ulcers and amputations. Finally, preventive care should be addressed, including reinforcement of a healthy diet low in saturated fats and refined sugars, regular physical activity, and vaccination against influenza and pneumococcus. As patients with diabetes have impaired immune function and are at increased risk of infections and their complications. In summary, the key issues addressed in this patient are his suspected acute coronary syndrome, multiple uncontrolled cardiovascular risk factors, and suboptimal diabetes control, all of which require comprehensive and coordinated management.